So, good morning. Welcome to ESC 2024. I'm Kaushik Ray. I'm Professor of Public Health, Consultant Cardiologist at Imperial College London, current President of the European Atherosclerosis Society. Welcome to this World Heart Federation event called Strengthening Secondary Prevention Strategies in Cardiovascular Disease Management. I need to have a quick shout out to a unrestricted grant and support to the sponsors, Amgen. So what's the focus of all of this? So secondary prevention is incredibly important. We've really missed opportunities to try and change the life course of atherosclerosis and sometimes end organ damage like heart failure. And what we're going to basically do is think about those individual risk factors, but think about policies. So it's not just about those individual risk factors, cholesterol, lifestyle, the role of, for example, cardiac rehab, patient advocacy. There are so many different players here. And importantly, we've got to bring together the health system, the physician, the patients, and we've got to do that at scale because there's 8 billion people on the planet. So we know that all of these interventions that we have will reduce our risk of cardiovascular disease, and we don't actually put them into practice particularly well. There are clear economic benefits between economic output and health. We saw that during the pandemic. We talk a lot about pandemic preparedness, but what about the pandemic of cardiovascular disease? So healthy people are productive. We don't need carers to look after them. And that means society actually benefits. And policy is so important. You need bottom up and you need top down. And we're going to hear about successful initiatives and also understand what some of the barriers are to overcoming some of these problems that we face. So I'm going to start off and we're going to go around. I've got 4 very distinguished people. They'll introduce themselves in a second as we go around, and each of them has expertise in different areas. So I'm going to start off with you. So Irene Gibson, could you just introduce yourself and tell us what you do, please?
So Irene Gibson is my name. I'm a cardiovascular nurse specialist and I'm based at the National Institute for Prevention and Cardiovascular Health in Galway. So a lot of my work is actually community-based as well as research. And in particular, my area of interest in research is digital health.
Very good. So I want to start. So we've got so many people that have got disease. We think about doctors, but it's not doctors, healthcare professionals. And cardiovascular nurse specialists have a very important role to play. So how do you see the integration of cardiac rehabilitation programs in particular in secondary prevention and some of the key benefits for patients that you've experienced during your time doing this?
Yeah, so I mean, we certainly know for patients who've experienced a cardiovascular event that prevention is vital and that up to 40% of cardiovascular events are recurrent events in this patient group. So it's absolutely essential that we provide them with access to prevention services. And of course, early initiation is key to this. The benefits of cardiac rehabilitation, I mean, they're so well established. We have decades of evidence. I mean, recently we had the 4th Cochrane review published in terms of highlighting the benefits of cardiac rehabilitation. So we know it's proven to reduce mortality, reduce hospital readmissions. Of course, it improves quality of life for the patient. And that's why, I mean, it's a class 1 level A recommendation. But I think it's really important to highlight that despite these really well-established benefits, that implementation of cardiac rehabilitation, like other secondary prevention strategies, is completely suboptimal.
Before we go to the next question for you. So I remember 20 years ago coming back from the States, and I thought, we just unprove it and thought this is great. The reality hits. And the Centre of Excellence, Cambridge. And you know what cardiac rehabilitation was for? And I took over the service. The interventional cardiologists were basically thinking that those people that, let's say, hadn't had an intervention, they were the ones that they'd put through, the older patients, etc., rather than it being holistic. So not everybody takes up cardiac rehabilitation. How can we overcome that?
No, so I mean, I think it's fair to say there are barriers to cardiac rehabilitation at multiple levels. So at the individual level, at the healthcare professional level, and also at the system level. But I think if we're talking at the individual level, I think what we need to do is we need to look at different ways of delivering cardiac rehabilitation. So currently in its format, And cardiac rehabilitation, you know, we've seen how cardiovascular disease and the treatments have evolved over the last number of decades. But cardiac rehabilitation has not really evolved. We're still delivering it in the hospital. We're still calling it rehabilitation. And the concept of rehabilitation emerged from the idea that people spent weeks of bed rest, had weeks of bed rest, then moved to the chair and so on. So we absolutely now, and again, we're probably very late coming to the table with this, but there are alternative ways of delivering cardiac rehabilitation. And we need to look at ways that work around, that are person-centered, first of all.
You've got to make it convenient for them.
You've got to make it convenient. It's not no longer satisfactory to deliver cardiac rehab 9 to 5 in an acute hospital setting. So we have to look at more innovative ways to deliver
in the community, for example.
In the community, for example, using digital means.
Well, I'm going to bring you up. So you have co-designed digital health interventions that, and the purpose of that is scalability, to make it easier. I mean, you know, there are apps for everything. And I'm going to bring Jules in a second to answer a point around that as well. So can you elaborate on what you did and what the benefits were for the patients?
Sure. So we know that, and of course, the whole advent of digital technology was very much, you know, the COVID-19 pandemic has brought this all to the fore. So we know that with digital health interventions, they can increase access. And, you know, we have seen
it's about equity.
It is about equity. And of course, you know, we know with digital health interventions, there's so many of them out there. But one of the challenges with digital health is engaging the patient and actually looking at all of these interventions, how can we enhance uptake and acceptance of these digital health interventions? So some of the work that we've been doing at the University of Galway is looking at developing digital technologies to look at that point of care when the person has immediately had their event and introducing them to digital health at that intersection. So bridging that important care gap between hospital and home, and really looking at how we can enhance self-management and importantly support patients in managing their cardiovascular risk factors. So everything from their lifestyle to tobacco, which includes tobacco cessation, diet, weight management, physical activity, to medical risk. It's a holistic approach with interdisciplinary input. So what we have done is we have worked with a group of end users and stakeholders that involve both patients, but also importantly, healthcare professionals and also individuals who work in healthcare to design and develop an intervention. So we've just brought it through the whole pathway of digital health development. So from the initial planning to the co-design, to the feasibility testing, and we're now ready to look at scaling up.
Well, that's brilliant. And the great thing about digital is it can be transposed, it can be moved to other areas, language can be changed and it's adaptable. Jules, you had a burning comment. I saw your hand raised. Do you want to just introduce yourself?
Thank you. Yes, I'm Jules Payne. I'm the Chief Executive of Heart UK, the cholesterol charity. So two things for me, really. One is when patients are released from hospital, they're being released, being told they're fixed. They're not.
Yeah.
And so I think we have to, here we are at ESC today, please do not do that anymore, because they're not fixed. This is a condition they will have for the rest of their life. They need to understand, they need to feel empowered to deal with it themselves in collaboration. The other thing I'd like to see, talking about digital rehab, this is such an important time to keep that focus, because when patients are just had their first MI, hopefully they won't go on to any more, but they need to be reminded all the time. It's not just rehab for 6 months.
Well, it's a lifetime. It's a life course, isn't it? You're making up for all those years missed.
So using the digital rehab to just keep that touch point going.
That's very good.
Throughout the rest of their life,
solution.
I think it's very important.
Brilliant. So I want to now bring in Ms. Birgit. Would you please just tell us your background and where you're from, and then I'll...
Very happy to be here with you together. My name is Birgit Beger. I'm the CEO of the European Heart Network that brings together heart foundations and patient associations across Europe. So that is my background, and I'm pleased to be here.
Well, your background is more than that, isn't it? Because I have here in my notes that you're involved in some of the policy initiatives around cancer. So cancer from a patient perspective, both what you were saying, I mean, so relevant. It means something for patients. Oh my God, it's this. We can see an end date, if you will. And we don't, because of some of the successes in managing cardiovascular disease. So what can we learn from the cancer field that can be maybe applied for secondary prevention from a policy standpoint, policy initiative?
What across Europe helped cancer a lot is a European beating cancer plan. So there's a political consensus that society undertakes a war against cancer, and that there's a structured plan, finance plan, and this involves patients. This ones involve the specialists. This involves politicians. It was a very broad spectrum, and that also research was much pushed forward. Otherwise, we wouldn't have successes in immunology. So that was very, very important, and we need the same in cardiovascular health, a plan which dedicates resources, political will that changes the life of people at national level, but also on EU level. That needs very concrete measures, guidelines, proposals, also for secondary prevention. But we very much see it. It's
as a life course, all stages.
Course, holistic. It's the entire pathway of the patient from primary to tertiary prevention, which needs to be covered. And that digital can be a tool, but it is really an all society approach, and all stakeholders have to work together. It's the technology, it's the pharmaceutical aspect, it's the doctors, it's the patients.
Multiple stakeholders.
It's multiple stakeholders.
And what do we know about what the EU plans to do in the coming near future, the next 5 years?
Very hot, yeah.
And if so, what should they prioritize?
First of all, we need that plan really undersigned. The Parliament wants it, the European Parliament. Many member states have national health plans for cardiovascular health now. Germany just 2 days ago. So it's a wave in Europe, and we need to have that everywhere. And then I think needs each political entity needs to put money in there and implementation, because you were discussing implementation. We can have the best plans, but if they are not implemented with people on the ground, patients, we are getting nowhere. So this is very important. And very important is also to be detailed. Secondary prevention. We work a lot, European Heart Network, on the early detection and screening. So that is very important to catch people before they get sick.
So what do you think at the moment are the main barriers for implementation? I mean, the one thing that I sometimes think about is non-communicable diseases, chronic conditions that are largely asymptomatic until the moment they aren't, are a huge problem. So we're going to touch with Jules in a second on patient awareness, advocacy and other aspects. But in terms of implementation, so we've got the data, and year after year, we've all done registries where we've looked at how slow we are. Why is that?
I think there's also a lot of answer in the healthcare system. We are talking Europe. It's a health equity. You mentioned it. It's completely different if you're a woman in Bulgaria or if you're a man in the UK. You will have to stand other systems to access the system to get there. And I think this is this leveling, what we can approach if there are national or European plans that set a certain standard.
Well, it sets a framework, doesn't it?
Exactly.
And then you try to import it and resources to do that.
And the connection also for physicians, for experts to interact digitally using imaging. I think we can reach a lot of areas.
Well, avoiding the silos, right? Exactly. Because everybody's got their silo. I'm doing this, I'm doing that, but we need the patient
connection.
Is connected by all of that.
Yeah.
Thank you for that. I'm going to bring you back a little bit later on in the discussion, but I want to move to you, Jules. So you've already introduced yourself. So at Heart UK, so you've talked. I've known you for many, many years about raising public awareness and the importance. You've focused, obviously, Heart UK, a cholesterol charity, but evolving more to thinking about cholesterol risk and lowering cholesterol for benefit, rather, because one of the problems with a hyper anything is that most of the heart attacks that occur don't happen with a hyper anything. They happen with lots of things added up. And we've lost the narrative a little bit. Doctors and patients won't treat often as a result. So I know you've been working on that. So in terms of Heart UK, what can you tell us about raising public awareness about the role of cholesterol lowering rather than hypercholesterolemia, and in terms of prevention of cardiovascular disease, secondary prevention in particular?
So it's all going to start with awareness. So whether you've had a heart attack or you haven't had a heart attack, it's all going to start with awareness, because you need to raise awareness of the dangers of the risk of people developing. And I was on the radio this morning at 5:40 talking about risk and making sure that people are aware to manage that, because it just could save their lives.
Yeah.
And that's such an important point. Take it seriously. It's often a silent killer. Know your numbers. It's quite straightforward. You can do something about it. Save your own life. and keep your family together. So this is really important. So we do a lot of awareness raising, as do other patient organisations around the world. And there are many examples. There's many awareness days. We have National Cholesterol Month in October of a whole month. And there's a lot of that going on. One campaign that we have done is a Get Back in the Game campaign that we did at Novartis, which is brilliant, multi-channel, and it was focusing people that have had a heart attack. And one case study that I can tell you is that this chap did not access rehab. He had had a heart attack. He was definitely on his way to his second. He was sat in his study and a bus went along. He looked out the window and he had a Get Back in the Game campaign advert on the side of the bus. He then thought, what's this all about? We explained to him it was about getting him back in the game so that he could be more active, actually helping him to feel empowered to take action on his own health. And he did. And I'm pleased to say he didn't have that second heart attack. He is looking after himself. So it is about getting back in the game. And it's patient organisations that can help with that. Now, there has never been a better time to empower patients. And every country needs that because it is part of the system. The patients are part of the system. The public's part of the system. It can save costs. People need to take responsibility for themselves and collaborate with third sector organisations such as Heart UK, with their clinicians, with their family, with the system. So everybody can help. Healthcare professionals are part of that and a very key part of it in terms of how they're communicating with the patients and how they're working with the patients. So it is a true collaboration to make sure people stay alive, do not have their second or third heart attack, and actually do true prevention.
Well, I want to bring, I mean, you've touched on so many things, but one of the key things there is about patients and trusted organizations as partners, because there's a lot of misinformation, as we know, and we've got to do that. And that's a lot better coming from a patient organization than, often physicians, scientists, etc. So one of the things we did very early on, it's actually almost 10 years ago now, I set up the F8 Studies collaboration, and data's fine. And you can write a paper and you can stand at a meeting like this, but unless you actually bring that out, and the only way to do that were through, so you were one of the first people I spoke to, and you've come annually to our meetings. And all of that data that we've produced that's impacted now policy around Europe, around newborn screening now is being tested in Germany, for example, and we hope that will go forward. What's the role that charities like Heart UK can play in bridging the gap between guidelines and things like knowledge, patient awareness, understanding, adherence?
For me, charities are absolutely integral in the whole system. We play such a major part because with appointments, there's not a lot of time for clinicians to talk to the patients. So we are the backup, if you like. So we can do that. We can help people. The most popular query that we get on our helpline is, I've just been diagnosed with high cholesterol, but I don't know what to do about it. We're often hearing, interestingly, latterly in the last few months, I can't get into rehab. Can I access private rehab clinics? Which is fine for those that can afford it, but there's a problem. So this comes back to how do we work with the system to get that done? Now, I would say that we're actually the bridge, but I would say we're the glue between the systems, actually, is what I would suggest we are. The other thing that we play a really important role in is holding the system to account. So I don't like the word no. So we do not have child parent screening at the moment for cholesterol. I would like it. We've been told no 3 times. We do not like that word. We will carry on till we get a yes. And we can do that. Healthcare professionals would struggle to do that on their own. We also bring together the system to help them network, to share challenges, to share solutions to those challenges on a monthly basis. We also recently published our Prevention Pays piece of work. This has demonstrated that if you did prevention properly, you could save over £2 billion a year, which is equivalent to £7,000 nurses a year extra. That's huge if you actually did prevention properly. Now, we're working on a practical plan. How can that be practically applied in the system? Because you're absolutely right about that. at the end of the day, for me, what we should be focusing on is actually primary prevention, because I'm sorry to say at a cardiology conference, we should be putting the
Oh,
cardiologist
no, I've just come from
out
an
of
intervention
work.
session and I talked about primary prevention. There was silence. It was about cholesterol lowering after angioplasty.
If we do our job well,
There won't
and
be, yeah.
the collaboration it works beautifully across the whole system, within a few years.
And it's not either or, is it? We need to do all of those because there are people being born. There's a whole bunch of people 20, 30 and 40 walking around out there going to work today and who are going to have a problem in the future. And there are some people who are a little bit older that have just had a problem. And we can't afford to lose any of them. But it's different approaches.
There will be heart attacks. There still will be a need for a cardiologist, of course. We just don't want as many because there shouldn't be.
We can't have, with a growing population, 8 billion people, enough hospitals, ambulances, cath labs, cardiologists, rehab nurses, etc., unless we start here and work forward.
Exactly right. Exactly right. And I just think, it is that it comes back to collaboration again. But the patient is, and I say patient because we're talking secondary prevention here. I like to think public because we'd like to get to in
Or
before
citizen.
that. A citizen. Thank you. So for me, they should be at the absolute centre of absolutely everything that we are doing. All the organisations, all the collaboration, it should be the patient at the centre of everything.
Well, keep that thought because I'm going to bring in, you've waited very patiently, Dr. Abhinav Sharma. So could you tell us where what you do and where you work?
Well, thank you so much for the kind invitation. My name is Abhinav Sharma. I'm an assistant professor in the Division of Cardiology at McGill University in Montreal, Canada. So I'm a cardiologist and I spend half of my time treating patients with cardiovascular disease and metabolic disorders like type 2 diabetes, obesity, etc. And the other half I do research. My research stream focuses essentially on two main aspects. The first is the use of novel digital tools to create, if you want to call it, digital biomarkers in order to screen, identify, and get the right patients to have the right treatment at the right time. The second is how can we restructure care delivery, both in the inpatient and outpatient setting, to really optimize care delivery, because there's so much we can do in just restructuring care that doesn't cost a lot, if anything, that can really make sure that we get the right patients to get the right treatment at the right time.
So, I mean, that's brilliant because essentially we hear, obviously, post-COVID, we had a lot of money thrown into that and it was needed. And then we hear, oh, there isn't any money, but there are efficiencies that can be gained. You've touched on diabetes, and at a conference like this around prevention, we know the global prevalence of diabetes, 7%, that will be over 11%. The population attributable risk from diabetes, both for coronary disease, heart failure, kidney failure, all of those is going to be huge. And then we've got the people we'd like to prevent them having a problem, but who have severe end organ damage, heart failure. In terms of your program, what are the learnings from, for example, heart failure and diabetes in terms of some of the things you've touched on? And I'll come to digital tools in the next question, but what are the things that you've learned that have improved? You talked about changes in the health system around those. What have you done?
Well, so it's really interesting because we were talking about secondary prevention and that there's often a lead up to someone having an event. So conditions like heart failure don't just happen out of the blue. There's often a slow buildup of risk factors, of cardiac structural changes, of environmental changes that lead to the development of heart failure. Even amongst patients who've had a heart attack, it can often slowly build up to a point where congestion develops. And heart failure in North America and in many parts of the globe is one of the most common causes of hospitalization and is a huge burden of cost to the healthcare system and has huge impacts on patient lives. So the question is, how can we actually identify these patients sooner rather than later? The same thing for diabetes. In fact, a lot of patients we see with their heart attack, you test them for diabetes and that's the first time they realize, actually, my sugars have been super high and have never been identified. COVID really exacerbated this, where patients were unable to see their family physicians, get routine screening, be able to be identified. So the digital studies we've been doing is how can we accelerate the identification of these types of conditions? I'm looking in the audience today and I see a number of people with smart watches, devices that can collect simple things such as heart rate, acceleration. And we think that, well, there's not much we could do with that besides provide information to users. But in fact, there's a richness in that information to the point where we can even use them to screen, maybe not diagnose, but to identify that someone is at high risk of developing heart failure or at high risk of developing diabetes. So we're using artificial intelligence algorithms to comb that data and to help identify people at risk so that they can take the appropriate steps of getting formally diagnosed and then getting on the right therapies. So it's about that prevention, identifying people before the critical event has happened. I think cancer has done a great job, when we talked about cancer, about screening and flagging that. I think we could do a much better job in the cardiovascular world, and digital may be one scalable solution to accelerate that type of screening and identification.
So, I mean, that's really interesting. So at Imperial, you're a big institution. I'm sure it's the same where you are. And then you never see them, all the other people at the university, and you go for one particular day and go, oh, that's really cool work you're doing. So about a year and a half ago, there's a group of researchers that are essentially looking at trying to do this so think about older patients and when they get really sick, falls, for example. So there essentially is like a lab with cameras, etc. So simple things like there's a normal distribution for you, and then trying to get out of your chair a little bit harder, a little bit slower, walk into your bathroom, a few more steps. If you basically mine enough data points, and you could do that through artificial intelligence in that way, scalable, you could, by putting those in, get people into the community, for example, and look at those people. You don't want to bring them in too early. You don't want to intervene when you don't need to. But potentially, you could pick them up at the edges of when things are starting. And that means we keep people in their own, but we don't institutionalize them. And, you talked a lot about that earlier on. So how do you personalize? How do you use digital interventions, for example, digital biomarkers or blood-based biomarkers, the availability of those, because a lot of these are research tools. How do you use those currently, and how does it guide your practice?
Well, that's you actually hit the nail right on the head in that a lot of these digital tools are able to be deployed outside of the healthcare environment. I think we really need to do a better job in distributing care so that it's not just delivered in a hospital or in a clinic, but actually in a person's home, in their home environment, where they're comfortable, and actually where most people spend most of their lives. And so we're actually doing a very limited job in assessing that. I mean, we see patients in a clinic, we check their blood pressure, heart rate, cholesterol, which is absolutely critical, but there's a whole life that's being lived outside of the healthcare environment. So how do we track that? And so what we've been doing right now is essentially either using devices people already own or giving devices for a short period of time to monitor people at home, to be able to track them in their own home environment. That data can be fed into a cloud where actionable data is identified. What we don't want is for a lot of data to be dumped in front of a healthcare provider and for him or her to make a decision based on tables and charts. We need clear, actionable results to identify individuals and identify when we should intervene. Not too early, but not too late. So those are the types of programs we're establishing and setting up. But we also have to make sure that we take cybersecurity into account. We take costs into account. Make sure privacy is really protected, because that's a big concern for a lot of our users. And some people are hesitant in using these technologies because of those concerns.
No, that's a very good point, isn't it? It's a very nice overview, because with data, I mean, I sign up and I can access my NHS data and sign approvals to use it for appropriate purposes and so forth. So that's a very good point about data, because there are people that will have concerns, rightfully, but we need to do our bit. Are there any questions or comments from the audience? I don't know if we've got a microphone, but while you're waiting to think about things, maybe I'll just bring you back in. So we've got lots of different solutions. So in secondary care, we've got a part of the care pathway, we've got policy. So for each of you, having listened to the other person and what they're doing, what's your take home from any of these question and answers that we've had that you could do not differently, build on what you're doing really well, but goes, actually, if I take a bit of this, I can do a little bit more?
Yeah. Well, I suppose one of the things for me is, and having listened to Jules and Brigitte and Abhinav, is for me, I think, and given that our audience here today is primarily healthcare professionals and researchers and academics and so on, is the importance of using our voice and the importance of collaboration and linking with other organizations, and importantly, linking with patient organizations. And I don't think we talk about advocacy enough. So you're right, we're great at doing the research, generating the data. I mean, we've had guideline after guideline. We've just had a fantastic session this morning announcing 4 new ESC guidelines.
Yeah.
But let's fast forward 4 years' time. How will the implementation of those guidelines be? And I mean, we've had Eurospar survey after Eurospar. We've had the results of Interaspar published today, 14 international countries. Only 9% of patients attended cardiac
I know,
rehabilitation.
it's
4,500
criminal, isn't it?
patients across the
Absolutely
globe.
terrible.
So, I mean, this is
A
scandalous.
proven-
It
yeah.
is scandalous stuff. So if we as healthcare professionals are serious about changing the trajectory of cardiovascular disease, not starting our academic papers with cardiovascular disease is the leading cause of death, if we want to change that, we have no other option but to work collaboratively with our patient organisation partners. And I have to really give it to the European Heart Network, the European Alliance for Cardiovascular Health, and the ESC Advocacy Committee and the World Heart Federation, because the inroads that are being made around from a policy perspective are really important.
So there's a framework.
We need the framework, we need the investment, we need to have a plan, but we actively need to be contributing to that. And that's why we need to sign the WHF petition today. In terms of calling,
Have you got the signature here? Can bring it out so everybody will sign.
In terms of
you
calling,
can't leave unless you've signed it. Let's bring it here.
In terms of calling for a national cardiovascular health plan for our own respective countries. Yeah. And for me, I think that is critically important, and we can do this.
So I mean, you'll remember this. So when we started off, everybody wanted, hey, we're going to do a global registry nationally. And I said, hang on a sec. So how many countries actually have a national organization? And you remember one of the things that I called it speed dating. And I said, for every single country, if there's a national registry for FH, there needs to be a national organization. And then there were many countries that didn't have national organizations that we helped. Well, you helped. And we put them together. We facilitated that networking to do that. So look at how many booths there are here, national societies. Each of those should have a national patient advocacy group alongside in that booth.
Yeah, I mean, I couldn't
That's
agree.
a simple win.
I couldn't agree more. And, you know, just to say yesterday, we had the first global cardiac rehabilitation and prevention forum, which happened here in London. And we had representation from over 40 different international societies on this very issue of secondary prevention and rehabilitation. We need more of this. We need more of this. And as you rightly say, given the representation here at the ESC, we absolutely need to have our patient representatives, our healthcare professionals, and our policy people here, and our politicians here. And we need to be,
Very good.
calling them to account.
Well, we've got somebody who's been doing that already. Birgit, anything you would like to add to some of the things that you've heard? I mean, there's a lot happening. Are there things that we can fast forward that you would focus on?
I think it is the for us where we have to come together. I mean, the solutions are there. AI, artificial intelligence, it can change completely the landscape, but we have to bring all this excellence together, and we have to create this for us and speak to politicians so they turn the wheel in fast forward in terms of planning and finance. But we have to convince. And if we all come together, the politician will listen to us. Not if the patient alone comes, not if the researcher alone comes, not if the doctor alone comes. No, we have to come together and say, well, we have a solution, A, B, C. This is the plan we wanted.
Here's a crazy idea. Go to every single parliament in the EU on a given day, check the blood pressure, check lipids, check HbA1c, EGFR, and if you have time, put them in a CT scanner and do a CAC score. Money will flow fairly quickly after that happens, particularly if it's the health minister that is doing that. Jules, you've been doing this, and I know, and you know, we've worked together, we've supported each other in many of these, and you're a fighter. You don't give up and say, the answer, there's no such thing as no, it's just not today. So what are the things that Heart UK are thinking about? You've heard some digital intervention. It's always, I know policy is important. It's always going to be music to your ears. And then we've got European level and we've got national level as well. What would you take away from some of the things you've heard?
For me, the stars are aligned is what I would take away from here, because I think we've got everything we need. We've got the personalized prevention approach. We've got AI involved. We've got the rehab. We need a bit more coming through. We've got the national policies in a lot of countries, not in all, but we do have European and worldwide policies, and I think that's important. But it's all about local. It's all about local, so it has to be drilled down. And so for me, do prevention properly, ring fence ring fence prevention funding
Yeah.
correctly, so that you stem the flow of the ambulances whilst you're dealing with the primary prevention. So you've not got the granny turning up all the time, and you're gradually we'll see a change. It's not going to happen overnight. It'll take a few years, but then putting the patient at the centre. And certainly Heart UK, we've launched a change maker program. So this is having patients actually working with the system in their local area to bring down the barriers. At the end of the day, us healthcare professionals, pharma, cardiologists, you name it, patient groups, etc., we all want the same thing.
Yeah.
We all want to save patients' lives and for people to not
And
have
it's quality of life.
It's quality of life, but it's the what then. We have to we can have the policy, we can have the focus of the local systems actually doing projects in their local areas, but actually it's the what then. But the key thing is make it convenient for the patient. Cancer's done it. You can have you can have treatment at home. Let's do that because it's convenient.
Well, it's the understanding aspect, isn't it? So cancer's got this emotive word, cardiovascular disease, sort of, but we still think but we've got a lot more time. Arvind, so you talked very nicely about all the things that you do at sort of that interface at the personal level and to optimize that care. In terms of what are you doing in terms of working with patient organizations, policymakers, because you could be the center of excellence at McGill. What about the rest of the state? What about the rest of the country? You know, global health. Let's talk about population health. Is about every single clinic doing the right thing in your hospital, and every single hospital in your city, and every single city in your country. If you add all of those together, we improve the population, whether it's a country or the planet. So what might you do, or what are you doing with these other sectors?
Well, that's a great point, because a small incremental change across multiple centers leads to big change overall. And actually, through the World Heart Federation, and actually I'm collaborating with Irene on this, we have a digital project, it's called where we're trying to understand at a global level what are the barriers and facilitators for actually implementing a lot of these technologies. You know, as we've heard from my colleagues, the knowledge is there. Each center has a vast, institution, infrastructure, and there's so much we can learn from each other. But we really do need to understand what's happening at that local level, as you mentioned, Jules, and to be able to understand what can be some barriers and facilitators of actually implementing these technologies. So we're working with the World Heart Federation and received a bit of funding through the World Heart Federation to understand this at a global level, looking at specific interviews with stakeholders and looking at what's out there in the literature, because there's so much, but it often needs to be synthesized in a way for everyone to access.
And one key thing about this, I mean, both of you have highlighted, so you've got to personalize it because there are cultural differences, there will be health beliefs, perceptions, there will be what's available in terms of resources. So you can take a scaffold, you can take a blueprint, but that's a starting point to shape it into something that works for you and operationally that works for you. So do we have any questions, or are you kind of like dumbfounded by everything that you've listened to?
Can I just say guidelines need to be written for patients?
Yes.
It's very complicated.
Yeah.
So I think we need to
They need
simplify
to be
everything.
involved in the writing.
Exactly.
It
Bottom
needs to be
up
simplified,
approach.
Well, I think, one of the things you'll see on Sunday, for example, so I'm chairing the late breaking registry session, and there are about 6 talks that are incredibly relevant. 2 of them come about simplifying policy and the benefits that you can get in terms of outcomes and body counts. And, it's very hard to generate that sort of information because our guidelines will look at trials and go, well, I did this, I'll add this in, I'll add this in, I'll add this. And this is a stepwise approach. And there are things, we've got enough evidence. So there'll be evidence that's shown. We're presenting 3 of those on back-to-back on Sunday. So for those of you there, put it in your calendar for 1:45 on Sunday. But for each of you, I want to basically one take home for the audience from your area that you want them to remember when they, it's fine being enthusiastic at a meeting like this. Everybody's taking selfies outside those signs. Come Monday, Tuesday, whenever they get back, it's all forgotten. So what's your one take home for everybody? What would you like to see them do by next year?
So I guess my one take home would be really just to ask yourself, what can you do to improve care in your centre? And again, back to my previous point, how can you use your voice to make a difference?
Very good. Birgit.
Yeah, I think it's the excellence in each and everybody to put work in their area and try to help bringing it all together with the politicians and being out there, bringing the voice, bringing the awareness for everybody of the need of cardiovascular health throughout Europe.
And that's important because I'm always surprised when I talk to colleagues around the world, is that how it hasn't dawned on them to think about wanting to be involved and talk to policymakers and a voice in isolation. I manage my patients. Yeah, but you're part of a bigger community. Exactly. We are not alone. Jules.
Put the patient at the centre of everything, make it convenient for them, but collaborate. And I think, so that is exactly what I would say.
Very good.
Let's make cardiologists redundant, reduce the number that are needed.
I'm going to retire soon
Sorry
anyway,
about
so it doesn't affect me. I've enough.
A lot of fantastic comments here. I think the big thing is there's so much fantastic work being done all around the world. We don't need to reinvent the wheel.
No.
We can take the lessons from these fantastic, institutions, foundations, charities, and distill that knowledge. I think that would be my big take home is there's great work, and how can we just leverage that information and apply it locally?
Brilliant. So, I mean, the only thing that's left to say from me is to thank the World Heart Federation. There are a series of these covering other important aspects of cardiovascular disease all through the ESC. I want to thank the support of Amgen for facilitating this, and the WHO, and my wonderful panelists for a really interactive discussion with incredible insights, and actually hope that we've got the bits, we just need to do it better. And it's implementation, policy, and putting the patient together first. So thank you.
Thank you. Thank you.